This is the last section, so we're going to do two things. First, the one medication you'll most often push through a line you've just started, dextrose, for a patient whose blood sugar has dropped. Then the capstone, exactly how you pass the practical exam and finish this course. By the end you'll know when D10 is the right call, how to give it without hurting the tissue, and what the examiner is actually watching for when you have 6 minutes to put in a line. Let's bring it all together. Start with when. Roman 4 dextrose is for a patient with known or presumptive hypoglycemia, low blood sugar. In most cases you confirm it with a handheld glucometer. A low number plus an altered mental status is your green light. If you can't get a reading, the clues still point you there. A known history of diabetes, an altered patient, sometimes alcohol on board. You are not treating a number in isolation. You're treating an altered patient whose sugar is low. That picture, confused, sluggish, maybe combative, with a low glucose, is the classic hypoglycemia call that a line and some dextrose can turn around in minutes. Now, what's in the syringe? For years the answer was D50, 50% dextrose in water. But manufacturing shortages of D50 have made lower concentrations common, and 10% dextrose, D10, has become the everyday EMT-level choice. Think of D10 as the dextrose for your scope. Same goal, gentler concentration, given as a controlled infusion or in small repeated amounts rather than one thick push. It's a great example of something this whole course has hammered. What's in the bag changes, packaging changes, so you always read the label and confirm the concentration before anything goes in. Here's how you give it safely, and this is the part the textbook is firm about. Dextrose goes through a large bore patent Roman 4. Confirm placement first with a good flush or free-flowing fluid. Then watch the site continually as it runs. Why so careful? Because dextrose that leaks out of the vein, extravasation, causes real tissue destruction and edema. A blown line here doesn't just fail, it injures. So the rule is simple. Large bore line, prove its patent, eyes on the site the entire time. If you see swelling, pain, or the drip slowing, you stop, because the cost of pushing on is dead tissue. Once it's in, your job isn't over, it's barely started. Reassess. Recheck the blood glucose and recheck the mental status, because that's how you know it worked. And know that rebound hypoglycemia is possible. The sugar can drift back down after the dextrose wears off, so keep monitoring, and when the patient is awake and able to swallow safely, encourage them to eat. A sandwich does what the syringe can't, it holds the line. One more consideration. In a malnourished patient or someone with heavy alcohol use, give thiamine consideration before or with the dextrose, per your protocol to protect the brain. Dextrose is a drug, so it earns the same discipline as every drug. Run the rights every single time. Right patient, right drug, right dose, right route, right time. Those are the expectations of medication administration, and they don't relax just because the patient is sick. Then document what you gave and when, and monitor for both effects. The desired one, a patient who wakes up and a glucose that climbs, and the adverse one, an irritated or swelling site. Give the drug, write it down, watch the patient. That habit is what separates a safe medic from a lucky one. Now the capstone, the practical. The exam is the NREMT Roman 4 therapy with fluid bolus skill. 20 points total, and you walk it start to finish. Several points are things you say out loud while you work, so the examiner knows you do them on a real call. You take body substance isolation precautions before the venipuncture. You note the flashback in the chamber. You dispose of the sharp immediately at the point of use, and you observe the site and the patient for the desired effect and for any adverse reaction. Score the points by doing the steps and verbalizing the safety. That's the easy part. Here's the part that actually decides pass or fail. The critical criteria, the automatic fails. You get a patent, properly adjusted Roman 4 within 3 attempts, inside a 6-minute limit. Run out of attempts or run out of time and it's over. You take protection before venipuncture. You don't contaminate the field without correcting it. You use no technique that risks uncontrolled bleeding, shearing the catheter, or an air embolism. You dispose of the sharp immediately at the point of use. And through all of it, you manage the patient as a competent EMT. Tape these to your forehead. Everything else is recoverable, these are not. Let's slow down on those, because each one is a trap people walk into. 3 attempts, 6 minutes, so don't fish. If a stick fails, pull, manage it, move to a fresh site and keep your clock in your head. Protection before venipuncture means gloves on before the needle, every time. Correct contamination the moment it happens rather than carrying on. No technique that could cause uncontrolled hemorrhage, shear the catheter, or introduce air. Sharp into the container at the point of use, not on the bed, not in a pocket. And manage your patient like a clinician throughout, not a technician staring at an arm. Passing the exam starts long before exam day, and that's the course requirement. You'll complete 20 Roman 4 starts on the mannequin. The 20th is your instructor sign-off, proof you can do it clean and unprompted. Then 5 live sticks on classmates, each one monitored by an instructor. That ladder 20, then 1, then 5 is deliberate. Build the motor pattern on plastic until it's boring, prove it once for sign-off, then earn the real skin confidence that no mannequin can give you. Do the reps. The student who's done their 20 walks into the practical calm, because their hands already know the answer. A word on those live sticks because they are different. Get consent and talk your classmate through it. Communication is part of the skill and part of being safe. Go distal first, the back of the hand or low forearm, so a miss leaves you somewhere to climb. Anchor the vein with your free thumb and commit to one clean attempt rather than digging. And afterward debrief. What did the flashback feel like? What would you change next time? These are real people doing you a favor. Treat every stick as practice for the patient who can't choose, and you'll build habits you're proud of. That's the course. You started not knowing why a line matters. You can now justify one, choose your gear, find a vein, run the procedure to the NREMP standard, calculate a drip, and push D10 safely. Go do your reps, pass your practical, and start your lines like someone who knows exactly why. Your full bibliography and credits are on screen.